And hello, everyone. Welcome to the Health Channel, all health, all the time. I'm Andrew Schmertz. Today, we're talking about a disease that is arguably the one women fear the most, breast cancer. I'm here with Dr. Jane Mendez, Chief of Breast Surgery at Miami Cancer Institute. Dr. Mendez, breast cancer is the #1 cancer with women, #2 leading killer behind lung cancer. These statistics are pretty startling. 1 in 8 women, a number that doesn't change much, will get breast cancer.
Absolutely right, and that's why it's a concern for everyone, and everybody knows a mother, a sister, a significant other who's been affected by breast cancer. And the good news is, though, that if we have earlier detection, we will have better outcomes for these particular patients.
There has been a tremendous amount of education over the past 40 years on breast cancer. Women fear it the most for a number of reasons. Obviously, it is cancer, it is disfiguring, but it is also one of the most treatable when detected early.
Absolutely, Andrew. That's it's even though it's the #1 cause of cancer deaths in women. If we detect it early, we have great outcomes for these patients. We're talking that nowadays, if somebody gets detected with early stage breast cancer, they have about 98% survival at 5 years.
85%.
So,
95%.
95%. So that is a great number. And it's because of the multidisciplinary approach. You know, whatever I can do as a surgeon, coupled by medical oncology, by radiation oncology, can really maximize the cures. But early detection is the key.
Yeah, and we're going to talk a little bit more about this. This is a cancer that humans have known about for a very long time.
You're absolutely right. You know, breast cancer was first described actually in the Edwin Papyrus, which was a medical document from 1600 BC. And at the time, they tried cold, they tried heat, and certainly nothing really worked, and it was incurable at that time. But luckily, since that time to the present, especially since the 1970s, with the introduction of screening mammography, we really had significant strides when it comes to breast cancer. And also to talk about the increased awareness and education that you alluded to in women.
Talk about the risk factors for women. To some extent, all women are at risk, and it could happen first at any age, and that's a really important message. There was a story a few weeks ago about a 24-year-old woman who was diagnosed with stage 4 breast cancer. Shocked her. She never even thought about it.
You're right, Andrew. It affects every age, and actually the incidence of breast cancer, the number of women with breast cancer increases with age. So the older the woman gets, the higher the likelihood of developing breast cancer. The youngest breast cancer patient I ever treated was 22 years old, and I didn't even want to believe the pathology because of her age, but sure enough, I repeated the pathology, and she had breast cancer.
And that's a devastating diagnosis at any age, but it's especially at 22.
At any age, and you know that the earlier you get diagnosed, the higher the likelihood that you develop a recurrence later in your life. So we have to really take that into consideration as we're looking at treatment options for these patients. And you talked about the disfigurement and just the self-image issues that are associated with breast cancer. So the younger you are, the higher the impact of these other factors that we cannot ignore that are part of the treatment.
Okay, what are some of the risk factors that put women at higher risk for breast cancer?
Yeah, so risk factors for breast cancer are multifactorial, and that's why it's so difficult to find a cure for breast cancer per se. You know, we certainly know that 85% of breast cancers are sporadic in nature, meaning that they occur out of the blue. 10% of women...
out of the blue in that there was no indications and no risk factors.
That, and that they had no family history.
Interesting, okay.
Yes. And then 10% of women is they have a family history without an identifiable genetic mutation as part of their family. And then 5% are the Angelina Jolies of the world, that they have an identifiable genetic mutation that we can act on.
And is that the BRCA gene?
That is the BRCA gene, and that is the most prevalent gene that is associated with breast and ovarian cancer. So when we identify genetic mutation, it allows us to then be able to take prevention strategies so that we can prevent the likelihood of the breast cancer. Other risk factors can include, some are modifiable, some are not. In terms of the modifiable ones, you can talk about exercise, diet, certainly environmental factors. The ones that we cannot modify, it's our age, you know, the fact whether you had children at a later age or not. if you had an early menarche, which is when you had your first period, you have late menopause, that also affects the likelihood of breast cancer, and you're being exposed to ionizing radiation. So it's multifactorial, which makes it really challenging.
Yeah, and let's talk a little bit more about the BRCA gene. It's also known as the BRCA gene is a major player, and we're going to have some more here on that.
You have heard about breast cancer, but do you know BRCA? BRCA stands for Breast Cancer Susceptibility Gene. Everyone has BRCA genes, but some women inherit BRCA genes that have a mutation or a change. Women with this genetic change have a greater chance of developing breast and ovarian cancer than other women. About 50 out of 100 women with a BRCA1 or BRCA2 genetic change will get breast cancer by the age of 70. CDC offers a confidential web tool called Know BRCA that women can use to learn their risk of having a BRCA gene mutation.
Learning your risk for a BRCA gene mutation allows you and your doctor to make important decisions for your health. This may include genetic counseling and testing, enhanced screening, and other methods to reduce your risk of ever developing breast or ovarian cancer.
Enter your family history, learn your risk, talk to your doctor. Visit knowbrca.org to find out more.
Doctor, genetic plays a small role, but a role in breast cancer, and specifically special demographic groups. How do you determine which groups and who is eligible for genetic testing?
Yeah, so when the patient comes to our clinic for consultation, we will actually ask about their family history. And depending on whether they have family relatives with history of breast, ovarian, colon, or prostate cancer, those are kind of the main cancers that we're concerned about as related to the BRCA gene mutation. But any other malignancy that exists in the family is important to know. So we see any red flags, then we will refer the patient for genetic counseling, where they will do an extensive family tree, and then if indicated, proceed with genetic testing for that particular patient. And there's many different tests that we can choose from when it comes to genetic testing in terms of which genes are checked for that particular individual, all based on the genetic information that the counselors have been able to obtain. So we really have revolutionized what we can offer patients from a genetic standpoint, not only in terms of the testing, but also in terms of prevention strategies. Because depending on the gene that is identified, then is the prevention measures that we can discuss with that particular patient and their family.
And some demographic groups are more at risk than others.
Yes, you're absolutely right. We know that the Ashkenazi Jewish population, for example, has increased risk for the BRCA gene mutation, and and in the African American women, we know that they have a higher indication for the triple negative breast cancer, which is the most aggressive because we don't have any specific targeted therapy for it. And the younger you are, the higher the likelihood of perhaps having a genetic predisposition. So we will certainly send those patients for genetic testing as well.
And some women have such a high risk for breast cancer, they voluntarily have their breast removed before they're ever diagnosed. That's Angelina Jolie is the most highest profile example there. When she had that, many people were shocked that someone would take this extreme measure because there's always early detection. Why did she do it, and why is that a consideration to be done?
That's a very important question, Andrew, and that is because if you know that you have the genetic predispositions, then it's just a matter of when you're going to develop the breast cancer. And when it comes to breast cancer, at least as you alluded to, we can have earlier detection, and we know the patients will do really well. But in my opinion, as related to the BRCA mutation carriers, the most lethal of the two happens to be the ovarian, because we have no good way to really screen for ovarian cancer, and oftentimes the patients get diagnosed at later stages. So this is an active conversation, and not all the patients who have the genetic predisposition, the BRCA gene in this particular case, will develop the cancer necessarily. However, a lot of women want to take control once they know they have this genetic mutation so that they have control of their life.
And you see different areas of the country take different action on this. When you were in Boston, I understand it was much less, but here in Miami, it's much more prevalent.
Yes, and that has been an interesting observation that I made since I've been in practice here for the past 14 months. You know, it's just a matter, could it be culturally related or not, or just fear of cancer itself, which oftentimes drives women to make these decisions for themselves. But the good news is that we have options, and we have a lot of education that we can provide for these women so that they decide for themselves what is the best for them in particular and their families. And one of the most interesting things that I've encountered is women who know they have the mutation and they decide to do nothing about it. Mm-hmm. They just want to wait.
And they would they have stepped up routine exams then? Do you counsel that a more frequent mammograms?
Absolutely. So when somebody has an increased risk or a known genetic predisposition, they have a much higher risk of breast cancer that fall in the category that we might need to alternate mammogram with MRI, which is the most sensitive test we can do to evaluate the breast, so that way we can detect something if it's there.
And how do you walk through a woman who may want to have this procedure done?
It's a very lengthy process. And with that, you know, it's a very long conversation because the patient needs to understand all the risks and the benefits associated with this decision, because it's just something you're doing to save your life and also to maximize the prevention of a cancer, let it be ovarian or, you know, or breast cancer itself. But you need to be prepared, you know, psychologically, physically. It's a very tough decision to make for a lot of women. Some of them have seen their own relatives go through the process, and that helps them in the decision-making process because they've seen a loved one also with the gene go through this process. But other times, some, they don't even know what to expect. And some of them haven't even had children of their own, and they're trying to figure out for themselves what is the best approach given their particular situation. I currently have a 25-year-old who's never had any children, found out she has the BRCA gene, and she's trying to figure out. So each time they come, you know, it's a very lengthy 1 hour plus conversation. Sometimes you even have to involve psychologists because you need to be ready for the decision when you make it.
Approach.
It has to be the holistic approach. And then we need to involve plastic surgery and others so that the woman knows what are her options when it comes to reconstruction, so that they get that image back and just the self-confidence that comes to a female and their breasts.
Okay, and early detection is key. Coming up, we're going to talk about diagnosing breast cancer, and of course, as it is true with any cancer, but especially true with breast cancer, the sooner the better. Please visit our website, allhealthallthetime.com, to send us questions, emails, or ask the doctor questions. We'll be right back. Doing terrific.
Each year, an estimated 12,000 women are diagnosed with cervical cancer. Thanks to improved screening and vaccination, cervical cancer is a highly preventable and treatable cancer. Early detection is key. Women should pay close attention to their cervical health by following these guidelines. Start testing at age 21. Women between ages 21 and 29 should have a Pap test done every 3 years. Women between the ages of 30 and 65 should have a Pap test plus an HPV test done every 5 years. A woman who has been vaccinated against HPV should still follow the screening recommendations for her age group. Your particular health history may dictate a different screening schedule for cervical cancer. Contact your primary care physician to talk about your history and schedule your next screening today.
SCAD stands for spontaneous coronary artery dissection, and it means there's a tearing in the walls of the arteries that bring blood to the heart muscle. In recent studies, it seems to affect more than 90% women compared to men. It's a disease that is not well known, but the causes can include certain types of artery problems such as fibromuscular dysplasia and other connective tissue disorders, as well as being peri or postpartum, and then other things such as emotional stress or extreme physical exertion. The main signs and symptoms are presenting with a heart attack, and those signs are chest pain, trouble breathing, any type of discomfort in the chest. People may feel lightheaded or dizzy or sweaty. And if you happen to have a predisposing disease of the blood vessels, then definitely have a low threshold to getting help.
CAR T-cell therapy is a revolutionary new treatment for cancer. Healthcare companies developing CAR T immunotherapy use Thermo Fisher's Dynabeads technology to isolate, activate, and expand T cells that have been genetically engineered to recognize and fight cancer cells.
We're taking the patient's own cells and enriching those cells to fight the cancer.
For more, go to thermofisher.com/CTS.
And welcome back to the Health Channel, All Health All the Time. Visit our website at allhealthallthetime.com. I'm here with Dr. Jane Mendez, Chief of Breast Surgery at Miami Cancer Institute. Dr. Mendez, we talked about women getting breast cancer. Many people may not realize that men get it too, and it's much more deadly.
Yes. So approximately 1% of breast cancers may occur in males. And certainly we don't have the same increased awareness in terms of early detection for the males. So that's something that we certainly have to work on. When it comes to treatment options, the treatment options are the same. And usually stage for stage, the outcomes are the same, but more males are diagnosed at a later stage because of the decreased awareness pertaining to it.
Yeah, a lot of men don't feel that they need to self-check.
Exactly. But certainly if the males have a family history or if they meet any of the criteria that we spoke about earlier in terms of potential genetic predisposition, then obviously we would send those males to be checked. And certainly any male diagnosed with breast cancer needs to be sent for genetic testing.
Okay, I want to take a look at our digital human animation. You can walk on over and walk us through a little bit about where the cancer generally occurs and how you treat it based on where it occurs.
Perfect.
So we could kind of take a look here at the animation.
So your breast cancer actually may occur in any of these landmarks. So the breast tissue is actually defined from the sternum all the way to the inframammary fold, to the clavicle, and down to the latissimus dorsi muscle, which is right here. So this is all considered breast tissue. And the first place where the breast cancer may travel to is here in the area of the axilla or the armpit. So that's why when we're checking and when the patients are checking themselves doing breast examination, they should cover that whole area, from the clavicle, sternum, inframammary fold, all the way to the axilla. And breast cancer, interestingly, occurs most commonly in what we refer to as the upper outer aspect of the breast, which is right here, because that's where most of the breast tissue lies. So we see a lot of breast cancers in this particular location, but breast cancer may occur anywhere in the skin, behind in the muscle, and in the axilla.
The cancer starts very small. How small is it that someone can detect it?
Well, the woman has to be aware what's normal for her. So that's why I think it's critical for the woman to perform breast examination and be familiar with what's normal for her. A lot of women will come to clinic and say, my breast is very lumpy, and they don't know what is normal for them. So certainly being aware of what's normal for them is critical in order to have early detection. So it depends. Some women present with little pea-sized masses, and others, is already a golf ball and they didn't even know they had
Yeah, I was
it.
going to ask you, how big can the mass get?
Andrew, there's no limit. The other day I removed a mass that was 11 centimeters. You know, it's really dependent on the patient. And also different breast sizes. The smaller the breast, certainly the less breast tissue you have to develop a mass. However, there's no limit to the size.
Once it spreads, where does it generally spread?
Yes. So as I alluded to in the anatomic diagram, the breast spreads locally first to the area of the axilla or the armpit.
And that's where
then-
some lymph nodes are as well?
Exactly, that's where the lymph nodes, and that's the first place where the breast cancer will spread or metastasize, so which is the scientific word that we use. However, once it spreads to the area of the lymph nodes under the axilla, then it has the potential to possibly spread to distant parts of our body, such as the bone, the liver, the lungs, and the brain. And the most common place where the breast cancer metastasizes or spreads to distally is actually the bone. Second most common is the liver, followed by lung, and then followed by the brain.
And how quickly does it spread?
Really hard to say. You know, some tumors are extremely aggressive and they can spread very quickly. And others are very slow growing and they can be sort of like brewing within the breast for a really long time, even before they have the potential to metastasize. So it's really driven by the biology of the tumor. And that's an area that we have really tried to unravel over the past few decades in terms of better understanding the biology and why do certain types of breast cancer prefer to metastasize to the lymph nodes and don't go anywhere else, whereas others very quickly metastasize to the area of the bones. And women can live really long lives, even with bone metastases, because of all the targeted therapies that we have available these days.
Okay, let's talk about the second line of defense. The first line of defense is self-checking, obviously. The second
Absolutely.
line is mammograms.
Yes.
How does a mammogram work?
The mammogram is the gold standard for the early detection of breast cancer. And the screening mammogram, it just entails two different views on each breast. So they do what is called the craniocaudal, so it's pushing from up to down, and then the mediolateral oblique, which is pressing from the inner part to the outer side of the breast. You get two views on each breast. The radiologist reviews the images. It's critical for the breast imager to review and compare with older mammograms to see if there's been a change. Was there a lump, a little density before? Is it bigger? Is it the same? Is it absolutely normal? Are there any underlying calcifications? Have the calcifications been the same or are they changing? So it's very important to compare with previous mammography so that we can increase the results of that given mammogram at that time. If there's any abnormality noted in that initial screening mammogram, then the patient will go what's called a diagnostic mammogram, and perhaps an ultrasound that will complement the mammogram so we can get more details in terms of that particular abnormality. It might be that it turns out to be nothing with the additional workup, or it might be that indeed the patient requires a biopsy after the additional imaging.
There's been some controversy over the years on how often women who have no risk factors or few risk factors should get mammograms. What's the current guidelines?
Andrew, I think in the past 20 years, they've changed the guidelines so many times. And each time it's created a lot of confusion for women. Every time the guidelines are changed, we see a significant decrease in the number of mammographies being performed. Ultimately, I think it's extremely important for the woman to, if they need to know their family history, they need to know their own risk factors so that they can have a conversation with their physician about screening mammography. It's usually advised for the woman to have the first mammogram based on around age 35. And even though the American Cancer Society changed the guidelines from 40 to 45, I think it's still important to have that conversation and for the patient to advocate for herself. We know early detection makes a difference. So why not?
There's no risk to mammograms.
Absolutely not. You know, the exposure to radiation is so small in the current mammogram machines that obviously it's okay to get a mammogram even starting at age 40. So in my practice, I try to educate the women and try to advocate for them to really have the mammogram at least at age 40 and annually thereafter,
And then,
especially
and
if they're
how
at risk.
frequently then after that?
It's usually annually.
Right.
Usually annually, and certainly this is talking about women who are at average risk, not talking about women who might be at increased risk with any of the genetic factors that we spoke about earlier, because in those women, they should have to start to get their mammograms 10 years before the relative was diagnosed with breast cancer. So oftentimes, that means if the relative was diagnosed at age 40, they should be getting their mammogram at age 30 or some type of ultrasound, at least some type of clinical breast examination at age 30, so they start the prevention strategies.
Okay, and we'll talk more about this coming up. We're going to talk about treating breast cancer. Life-saving treatments for cancer do exist. Many more women are surviving the disease. The cure rate in some cases, as we've discussed, is 95%, but only if you detect it early. Please head to our website, allhealthallthetime.com, to take a look at more information and for questions for our doctors. Stay with us here on the Health Channel.
Each year, an estimated 12,000 women are diagnosed with cervical cancer. Thanks to improved screening and vaccination, cervical cancer is a highly preventable and treatable cancer. Early detection is key. Women should pay close attention to their cervical health by following these guidelines. Start testing at age 21. Women between ages 21 and 29 should have a Pap test done every 3 years. Women between the ages of 30 and 65 should have a Pap test plus an HPV test done every 5 years. A woman who has been vaccinated against HPV should still follow the screening recommendations for her age group. Your particular health history may dictate a different screening schedule for cervical cancer. Contact your primary care physician to talk about your history and schedule your next screening today.
SCAD stands for spontaneous coronary artery dissection, and it means there's a tearing in the walls of the arteries that bring blood to the heart muscle. In recent studies, it seems to affect more than 90% women compared to men. It's a disease that is not well known, but the causes can include certain types of artery problems such as fibromuscular dysplasia and other connective tissue disorders, as well as being peri or postpartum, and then other things such as emotional stress or extreme physical exertion. The main signs and symptoms are presenting with a heart attack, and those signs are chest pain, trouble breathing, any type of discomfort in the chest. People may feel lightheaded or dizzy or sweaty, and if you happen to have a predisposing disease of the blood vessels, then definitely have a low threshold to getting help.
CAR T-cell therapy is a revolutionary new treatment for cancer. Healthcare companies developing CAR T immunotherapy use Thermo Fisher's Dynabeads technology to isolate, activate, and expand T cells that have been genetically engineered to recognize and fight cancer cells.
We're taking the patient's own cells and enriching those cells to fight the cancer.
For more, go to thermofisher.com/CTS.
Welcome back to the Health Channel, All Health, All the Time. We're talking today about breast cancer with Dr. Jane Mendez, the Chief of Breast Surgery at Miami Cancer Institute. Dr. Mendez, you're a surgeon, so obviously surgery is one option for breast cancer. Let's talk through all of the options. You have a newly diagnosed patient, maybe somebody who has gotten a diagnosis very early.
Perfect. So obviously that's the ideal stage, to be diagnosed early. So when, in general, there's two main surgical options for the treatment of breast cancer. Number one is what we allude to a breast conservation, where we can do a lumpectomy and just remove the area of the affected breast.
And lumpectomies are somewhat new, like 20, 30 years or so. They weren't very, they used to be take the whole breast.
Absolutely. That is the second option, which is the mastectomy, which is removal of the whole breast. We spoke about earlier, that would be including everything from the area of the clavicle, all the way to the sternum, all the way to the latissimus dorsi muscle here, and we leave the muscle behind. In the past, in the early 70s, they used to remove the muscle as well, but we don't do that anymore because we know it doesn't represent a survival advantage for the patient.
And
So
why do you not need to represent the muscle? Take the
Well,
muscle?
because at the time, which was the 1970s, we didn't have the good systemic therapies nor radiation options that we do nowadays. So certainly, the way that we've been able to maximize the cure for breast cancer is by what we refer to as the multidisciplinary approach to breast cancer, meaning I cannot do my work alone. Obviously medical oncology is part of the team, radiation oncology, plastic surgery, the breast pathologist, the breast imager. We all together figure out what's the best multidisciplinary approach to really maximize that given patient's cure. Oftentimes, it will include surgery followed by radiation. If the tumor is one that responds to estrogen, we might give endocrine therapy as well. And for cancers that have already spread to the lymph nodes, then chemotherapy might be one of the options as well.
Yeah, let's walk back a little bit on stages. So who would be good for a lumpectomy, for example, a good candidate?
So lumpectomy would be somebody who has a small mass and has a pretty good breast size. When we do lumpectomy, we really need to make sure that all the cancer cells are removed. So all the borders, all the margin around that lumpectomy have to be negative for cancer. So somebody who has a stage 1 and a stage 2 breast cancer certainly can be a good candidate for lumpectomy.
And we're looking at a graphic here.
Provided we can get the negative margin. So that's critical. And usually after you have the lumpectomy, that is followed by adjuvant radiation therapy. In the event there's any other cancer cell that is in that breast that we've not been able to detect by imaging, and the role of radiation is for further local control.
And stage 0 and stage 1, is that where the 95% survival rate is?
Exactly. That is where it mostly lies.
Okay,
yes.
and stage 2 is where the cancer is larger than stage 1. I
Yes.
assume some specific number, but it hasn't spread.
Well, it's actually interesting because the staging has changed for breast cancer recently as of January 2018. And now it incorporates a lot more of the biologic factors that are associated with that particular cancer. Because we've started to understand that it's not just size. It's just not whether the lymph nodes are involved with cancer or not. It has also to do with the specific biologic characteristics of that given tumor. So now with the staging, that has been included.
Okay, and then stage 3 is more aggressive, where the cancer has spread
Yes.
to the lymph nodes.
Yes. So in stage 3, that would definitely be a patient that will benefit from not only surgery, but followed by radiation and then some systemic chemotherapy, with the goal that since it's already spread to the lymph nodes, we want to also treat the patient systemically with the chemotherapy. So the way I like to conceptualize this when I'm having this discussion with the patients is, with surgery, we remove the tumor burden so that it doesn't continue to grow. With the chemotherapy, if it's needed, we treat everything systemically from the head to the toes in case something has escaped in the bloodstream.
And you may
And
not
the
pick it up.
radiation is for further local control.
And then stage 4 is the most aggressive cancer that has spread to other parts of the body. And how is that treated, and what does the outcome look like?
Yes, for stage 4, that's an area of controversy when it comes to surgery. Usually, surgery is not part of the armamentarium to treat stage 4 breast cancer. And usually, depending upon the site of metastasis, there's many different targeted therapies that we can use. But it's mostly up to the medical oncologist, let it be just endocrine therapy or in some instances chemotherapy, depending on the patient's symptomatology.
And chemotherapy has really radically changed over the years, and
Yes.
very recently, in fact, because of new biotech drugs.
Absolutely. You know, chemotherapy has really evolved. And now we have many options that we didn't have before. I call it now, before we had like 2, 3 options in terms of the regimens we could use. And now we can say that we have an alphabet soup of regimen options that we can offer to our patients. And most importantly, is somewhat targeted. So depending again on the biologic characteristics of that tumor, we can better choose what is the appropriate regimen for that particular patient and their cancer. And we've also learned about the side effects and how we can better control the side effects associated with chemotherapy so that the quality of life is preserved. And it's great for me when I even have patients that even while they're going through chemo, they still go to work and try to keep their life as normal as possible. So because we do as much to prevent the side effects as we do to treat the cancer.
People are tolerating the chemo better than they are. So
Yes.
almost all patients, I imagine, ask about what other options there are. And clinical trials could be an option for some patients.
Yes. You know, clinical trials is definitely a very important component. Certainly over the past 40 years, very, very important and pivotal clinical trials have changed the landscape of what we're doing today, thanks to all the women who were pioneers and decided to participate in those clinical trials. To see, you know, going from those radical procedures to the lumpectomies that we do nowadays is because a lot of women dedicated their time and effort and health to clinical trials. So oftentimes, if it's a very difficult case or the patient has tried many options, therapeutic options without good results, clinical trials is definitely a great avenue for patients.
And talk about some of the success stories, because you want to communicate to your patients newly diagnosed and say, look, I've been doing this for a while and I have great success stories.
Yes, success stories are abound, and that's awesome. And, you know, secondary to the fact that women live to tell the story, we have, you know, many, many breast cancer survivors. And not only are they surviving the breast cancer, but with good quality of life, which is the ultimate intent. So I try to encourage them, you know, it's a journey. And nowadays, some people even start to believe that breast cancer essentially could be viewed as a chronic condition like hypertension or diabetes, because with all the targeted therapies and appropriate therapy, women are living very long lives with great quality. So that's what I try to
full
inspire.
lives, right?
Absolutely.
In many cases, there's no shortage of life expectancy.
I would agree. I would agree. Yes.
For a woman who has been diagnosed and treated with breast cancer, what is the protocol on follow-ups throughout really the rest of their life?
Yes. So usually, you know, breast cancer monitoring and surveillance is really important that you've been treated for breast cancer. So we usually, if the patient had a lumpectomy, we will repeat a mammogram 6 months after completion of the therapy so we can get a new baseline. And then subsequently, if that one is normal, the woman would resume her annual mammography. And again, depending on her risk, she might need to get an MRI as well, but that's usually reserved for women at much higher risk. And if not, they just get annual mammographies. Clinically, we usually see the patient every 3 months for the first 2 years, because in the first 2 years after therapy, they have the highest likelihood of recurrence.
And
after
the first
6
how many
months,
years after surgery did you say?
2.
At 2
2
years.
years, yes.
And the general rule, and maybe this has changed, after 5 years, somebody is considered cured?
After 5 years, we see them annually with annual mammography because, yes, well, they're cured right after completion of therapy, right?
Okay.
And but we know that the risk of having a recurrence significantly decreases after year 5, and obviously they don't require as close monitoring as in the first 2 years or before that.
What does the future research look like out there?
Andrew, it's amazing. Everybody is looking for the perfect target, especially for the triple negative breast cancers. That is everybody's quest. Because for the tumors that are endocrine sensitive, meaning that are responding to the estrogen and the progesterone, we have a target. For the patients that have the HER2 receptor, we have a target, which is called trastuzumab. But for the patients who are triple negatives, meaning that they don't respond to either, they don't have those targets, we have nothing specific that we can offer.
This is the most aggressive cancer you're talking about.
Well, currently it's considered the most aggressive, but we don't know if it's because of its intrinsic biology or if it is because we don't have a specific target for it. So that's why it's such a rich area of research, and people are really striving to find a target that we can offer these patients.
Okay, and then post-treatment, women want to know about reconstruction. And still ahead, we're going to be talking about reconstruction after breast cancer surgery and how that can make a huge positive difference in survivors' lives. I want to tell everyone to go to our website, allhealthallthetime.com. You're going to find a lot of information about this program and this topic we're talking about, as well as past topics. You could email doctors and suggest future topics. We've got a lot of shows, a lot of days ahead, and we want to cover as much ground as possible. Stay with us here on the Health Channel.
Each year, an estimated 12,000 women are diagnosed with cervical cancer. Thanks to improved screening and vaccination, cervical cancer is a highly preventable and treatable cancer. Early detection is key. Women should pay close attention to their cervical health by following these guidelines. Start testing at age 21. Women between ages 21 and 29 should have a Pap test done every 3 years. Women between the ages of 30 and 65 should have a Pap test plus an HPV test done every 5 years. A woman who has been vaccinated against HPV should still follow the screening recommendations for her age group. Your particular health history may dictate a different screening schedule for cervical cancer. Contact your primary care physician to talk about your history and schedule your next screening today.
SCAD stands for spontaneous coronary artery dissection, and it means there's a tearing in the walls of the arteries that bring blood to the heart muscle. In recent studies, it seems to affect more than 90% women compared to men. It's a disease that is not well known, but the causes can include certain types of artery problems such as fibromuscular dysplasia and other connective tissue disorders, as well as being peri or postpartum, and then other things such as emotional stress or extreme physical exertion. The main signs and symptoms are presenting with a heart attack, and those signs are chest pain, trouble breathing, any type of discomfort in the chest. People may feel lightheaded or dizzy or sweaty, and if you happen to have a predisposing disease of the blood vessels, then definitely have a low threshold to getting help.
CAR T-cell therapy is a revolutionary new treatment for cancer. Healthcare companies developing CAR T immunotherapy use Thermo Fisher's Dynabeads technology to isolate, activate, and expand T cells that have been genetically engineered to recognize and fight cancer cells.
We're taking the patient's own cells and enriching those cells to fight the cancer.
For more, go to thermofisher.com/CTS.
Welcome back, everyone, to the Health Channel, all health, all the time. I'm here with Dr. Jane Mendez, Chief of Breast Surgery at Miami Cancer Institute. Dr. Mendez, women are surviving this in record numbers now. Every year, I think the numbers get better. So they want to then talk about options for reconstruction. So how does that process begin, and does it begin initially even at the treatment level?
Yes. So it's an integral component of the breast cancer journey. And actually here in the United States, it's approved by most insurance companies, okay, which is a right to a woman if they're gonna undergo some type of treatment for their breast cancer to also have reconstructive options. So we start the conversation, especially if the woman is going to have a mastectomy, it's a must. Most women, when given the option, at least they want to explore what are their options. So we refer them to a plastic surgeon for consultation. And there's two main buckets of reconstruction. Number one is one that is implant-based reconstruction. It could be either silicone or saline implants. And the other big option is autologous tissue, meaning using your own body tissue. So oftentimes we bring tissue from the abdomen to reconstruct the breast in the chest area. So it's the conversation that the patient will have with the plastic surgeon. Also depends on the patient's desires, their body habitus. I mean, and not all reconstruction options are available to all patients. But what is important is for the individual patient to know what her choices are and to make that very personal decision, as breast cancer, for many other types of cancer, is something that you're reminded to all the time because it's part of your body image as a woman.
Yeah, how good has breast reconstruction become over the years?
It's amazing. Anything from the types of implants that are available in terms of the different textures, in terms of the shapes available, silicone versus saline, so there's an option with that. And in terms of the autologous tissue reconstruction, now they're doing this microscopic anastomosis, and then that's only one component. Then we can do nipple areolar reconstruction, we can do tattooing.
Yeah, you had mentioned the nipple, because that was always one of the hang-ups in the past, that you could not save the nipple, but that option does exist now.
That is an option that we have for selected breast cancer patients these days. We might be able to perform what's called a nipple areolar sparing mastectomy, meaning that indeed in those particular patients, again, it's a small number, we consider it that it's safe and oncologically prudent to save the nipple in that particular patient. But I want to caution everybody out there that that's not the right choice for all patients, but it's definitely part of the set of options available to patients these days with incredible cosmetic outcomes.
Yeah, it's a hard conversation to have, because I'm sure that is one of the first questions you get after what is the treatment. Reconstruction, of course, is cosmetic, and that should not be the primary focus.
True, however, it's part of the holistic approach. If the patient is indeed a candidate for that immediate breast reconstruction, we want to make it happen. And sometimes it's not possible to do an immediate breast reconstruction, in which case then that patient in the future might have a delayed breast reconstruction. But it's an important component, it's part of the conversation, it's part of the journey for breast cancer patients.
How soon can you have reconstruction?
Well, if it's done immediate, I'll do my oncologic portion, and the breast a plastic surgeon comes and does his part that's considered immediate, same operation, same anesthesia. Oftentimes, if the patient is receiving a radiation after the mastectomy, we might not be able to do immediate. So then it's usually recommended to be performed no earlier than 6 months after completion of the radiation, so the skin has had time to heal. And actually, even in patients who have a lumpectomy but have significant disfigurement or asymmetry in one side as compared to the other, plastic surgery is also an option, because it's really hard to find clothing to get fitted properly. So even if they didn't have a mastectomy, because plastic surgery is part of the armamentarium.
Why, from a medical standpoint, when you reconstruct a breast, is there not a risk of the cancer returning? Because you're reconstructing some tissue in that location.
Yes. So usually, if it's an implant, it's actually positioned behind the muscle, the pectoralis major muscle. So if I were to look at this diagram.
Let's bring up the diagram of the breast
if
again.
we were to look at the diagram, so here's the pectoralis major muscle, and the implant is usually placed behind the muscle. So it will be sandwiched between the pectoralis major muscle, which is here, and then the rib cage, which is right here. So the muscle here, and then the rib cage here. So it's protected from the residual breast tissue. And usually when we do the mastectomy, all you have left is the skin. along with
And
the
so
muscle.
The breast tissue is removed.
Yes.
How often do you have to do a double mastectomy?
That is actually for the patients who have the known genetic predisposition, as we said, that is the recommendation. However, for those patients who have unilateral breast cancer and in the absence of genetic predisposition, those patients is a personal choice. And here in South Florida, I've actually seen an increase in women actually opting to have the contralateral side removed in the absence of genetic predisposition. So
If
a
they
lot
have
of them-
cancer in one
Yes,
breast.
and oftentimes when I ask them why, they really want peace of mind. And it's a very personal choice, but it's certainly part of the discussion when we have somebody. They need to know, though, that removing the other side doesn't improve their overall survival. But if it's something that they're doing either for symmetry or because it's their choice or because their fear of recurrence or their fear of developing cancer on the other side. So there's many factors. So it's an open conversation that we have with patients, but it's a very individual and personal decision.
Talk about the emotional impact that reconstruction has, because you are not only fighting a deadly disease, which has an emotional impact, you have the emotional impact of disfigurement.
Yeah, and I think as compared to many other cancers, I think breast cancer is unique from that standpoint because you're constantly reminded with your scars that what you went through. And I know that recently there was a movement about just going flat. You know, there's a lot of women who make art out of their mastectomy sites with tattoos and everything, but it's a personal decision, and I cannot stress that enough. And as a clinician and with the rest of our team, it is our duty to inform the patients of what their choices are, for them to be educated about what is out there so that the particular patient can choose for herself. And I agree, in the journey you go through such ups and downs because of the emotional component, which is unique to breast cancer as compared to others. And we really need to support the patient through that journey, which starts the day of the diagnosis but continues for life because they're constantly reminded of what happened. And furthermore, there's a lot of support groups, there's patient navigation, because luckily a lot of women have lived to tell the story, and there's a lot of support available out there for all stages of breast cancer and all age groups.
You talk about support. Let's talk about at-risk women for a moment, because we talked a little bit about insurance, but obviously not everybody has insurance. And the at-risk women, how do we reach them? And are we doing a good enough job about reaching them, about education and basically options for preventive treatment?
Yeah, so it's a task, you know, and it takes a village. And even though it's been very proactive over the past 40 years or so, since the introduction of mammogram in the 1970s, we still have a lot of work to do, especially in certain segments of the population. And there have even been studies that it's not necessarily just access to care, and there's many socioeconomic, cultural factors that also are the drivers that lead a woman to either follow the screening guidelines or not. And that's to the extent that, you know, we know that even nowadays, African American women have a much higher mortality as compared to Caucasian women when it comes to breast cancer, and they're not as prone to getting their imaging even when they have access to care. So there's still a lot of different segments of the population that we have to work on. And also we know that Hispanic women tend to also be diagnosed at later stages as compared to others, and that's because screening is not really
And that's
part
about
of the
access,
culture.
right? Access, education.
Access, education.
What is life after cancer for your patients like?
Well, it's pretty good, you know, and it's amazing to me when they come and I tell them at the beginning how it's going to be a blur of the past before they even think about it.
And we have a graphic here, by the way, of just some tips that everybody should be basically
so
doing.
not only do we monitor clinically, but we really advise them to live a healthy life. You know, basic things that are good for health in general, such as your nutrition, you know, your exercise, you know, obviously be moderate about your alcohol consumption, trying to reduce your stress level, and just be proactive about your health. Don't wait for something to hurt you in order to go seek medical attention.
Do you find your patients after the diagnosis really become serious now about their overall health?
Absolutely. They really want to ask and see what they can do to keep this from happening, what they can do moving forward to have healthier lives. And as a physician, that's really great to see that the patient has taken ownership of their health. Sometimes, these are wake-up calls, and nobody wants to go through the breast cancer experience, or any cancer for that matter. However, it changes people's lives, and oftentimes in a very positive way.
Yeah, and you're seeing more and more people hopefully come in at the earlier stages?
Yes, yes. And I think that's a product of the education, the awareness, and all the national organizations that have put great efforts over the past, decades when it comes to breast cancer awareness and prevention, and just women just taking charge of their lives.
Dr. Mendez, thank you very much.
Thank you for having me, Andrew.
That's all the time we have today. Join us next time on the Health Channel, All Health All the Time. Don't forget to visit our website, allhealthallthetime.com. You're going to find a lot of great information on there. Please join us next hour as we talk about another topic. I'm Andrew Schmertz.